Dr. Feingold, were you contacted by the Ocean County Prosecutor's Office in regard to the death of Corey Micciolo?
I was. Excuse me, I was.
Were you asked to conduct a review and render an expert opinion in that case?
I have, yes.
Did you prepare a report?
I did.
Would having it in front of you help you with your testimony today?
Absolutely.
Your Honor, may I approach the witness, please?
Yes, of course, you have to ask.
Thank you. S-161. I'm showing you what's been marked for identification as S-161. Is that your report?
It is.
All right, I'm going to leave that with you. Dr. Feingold, did you have the chance to physically examine Corey?
I did not.
What did you review in reaching your opinion that you're here to give today?
I reviewed all the discovery that your office provided to me for the case.
And when you say all of the discovery, about how many documents did you review? Not just pages, but entire documents.
104 documents, pieces of evidence.
And did you review any electronic items of discovery provided to you?
Yes, I did.
About how many of those did you review?
Maybe another 30. I'm not sure what the number.
Now, were there certain records that were of particular importance to you?
Yes. In order to render an opinion, the specific records which I found most relevant to me were the timeline that was given of the occurrence of events, the autopsy report by Dr. Ragazza, and then specifically the 4 medical records from the institutions where Corey was examined at the Ivy Pediatrics, the Community Medical Center here in Toms River, Jersey Shore University Medical Center, and Southern Ocean Medical Center. I also reviewed the report by Dr. Catherine McCann's, the forensic report from Dr. Thomas Andrew, the forensic report from Dr. Michael Bagden, and the short movie clip video of when Corey's mom was speaking to him in the car, and all the medical labs, including the toxicology reports and microbiology reports that were available.
Did you review Dr. Ragazza's report as well?
I did. I mentioned that, I thought, yes.
And did you review, as part of those over 100 documents, police reports and statements and transcripts?
Absolutely.
And photographs?
Everything that was available to me.
Now, after you reviewed all of that material, did you render an opinion with respect to whether Corey died as a result of some infectious process?
I did.
What was your opinion?
My opinion was that there was nothing available in all the discovery and the medical records that were consistent with infection causing Corey's death or even playing a role in it.
When you say nothing available, it didn't exist?
I didn't see anything that suggested infection.
And is that opinion to a medical degree of certainty?
Absolutely.
Now, did you review, or you said you reviewed the records from Ivy Pediatrics, right?
Yes.
And that would be by Dr. Deacon?
Yes.
Was there anything within those records that was important to you in regard to formulating your opinion that you're here to give?
Yes. So that visit occurred the day before Corey's death at about 5:20 in the evening, and at that time Corey was described as having had no fever, no complaints of any kind of physical ailment other than the marks on his body for which his mom had sought evaluation. He was afebrile, so no fever. His vital signs were completely stable, and he on physical exam, there was no abnormality, and in specific, The amount of oxygen in his blood was normal. He appeared to be completely well and have normal activity. His lung examination was completely clear, no abnormal sounds in the lungs. And so at that time, with a physician evaluating him, there was no evidence of any kind of infectious process.
And is it fair to say that was about 24 hours before Corey died?
Exactly.
Did you review the records from Community Medical Center?
I did.
And was there anything within those records that was important to you in regard to formulating your opinion?
Again, the findings were very similar. The vital signs were normal, meaning there was no elevation in his respiratory rate, in how quickly his heart was beating, and once again, he had no fever. In addition, he was described as alert, in no distress whatsoever, and his lungs were described as clear with no abnormal breath sounds. And so once again, and this was just a few hours later, but a second physician's evaluation found no evidence of an infectious process.
And what about his mouth and his throat? I'm not going to use the technical words because I'll definitely mispronounce them, but what about his mouth and his throat?
Right, his mouth looked normal. He had a normal amount of, sort of saliva and normal findings of his mucous membranes, and his throat was not red. There was no pus on his tonsils. So his exam was described as a normal, healthy child.
What about his lungs and his respirations at that time?
Right, his respiratory rate was normal. The oxygen in his blood was 100%, and he had no trouble breathing. He didn't work hard to breathe at all, and when they listened to him, there was no problem and no abnormal sounds or decreased sounds suggesting pneumonia. There was nothing in the lung exam there was nothing in the exam at all that they mentioned that suggested in any way that he had an infection.
And was all of that information up to that point important to you?
Yes, because what it was laying out was a time course, and so 24 hours before his death, he had no signs that he had an infection.
Did you review the medical records from Jersey Shore University Medical Center?
I did.
Was there anything within those records that was important to you in regard to formulating your opinion?
In addition to the findings that had been noted in the other visits, he had some laboratory work done at a Jersey Shore, which revealed a normal white count. So the sort of cells in his bloodstream that are fight infection were normal. There was a normal distribution of the kinds of cells that were there, and the only abnormality on his blood work was a slightly, sort of almost insignificantly elevated test of coagulation, the upper limit being 39, hinges of 40. That's really not anything we would pay attention to and consider sort of noise in the system. The other important information that was gathered at that visit was that Corey had no evidence of a significant viral infection, respiratory viral infection. So he was tested for COVID, he was tested for respiratory syncytial virus, he was tested for influenza A and B, and those were all negative. So again, the conclusion reading this was that he was, a well-appearing child other than the bruising that was noted, and he was described by the nurses as alert, appropriate, and walking normally with a steady gait. So again, this being the third evaluation, so we have three, physical examinations by physicians all of whom believed that this child was, and he did, look completely healthy, other than the bruising.
Do you recall approximately what time the blood was taken from Corey at Jersey Shore University Medical Center?
It looked like it was drawn around almost 11 p.m. Not quite, but
All right.
10 minutes shy of 11 p.m.
And so you went over there being a skeletal survey.
I didn't mention that, but there was no evidence of fractures from, I didn't mention it here, but that the skeletal survey was read as normal.
And no evidence of anything wrong with Corey's lungs at that time.
That wasn't mentioned specifically. I think had the radiologist seen anything in the lungs, he or she might have noted it, but that's not what that study concentrates on.
I understand. And so you mentioned the white blood cell count. Why is that measured?
The white blood cell count is measured because you can often find evidence of either inflammation, a stress response to a number of things, one of which can be infection, and that the white count may reflect changes suggesting that.
And you talked about the different cells that make up a white blood cell count. Could you
So
explain
there are
that?
two major populations of white blood cells. The neutrophils or granulocytes, which are the cells that typically respond to a bacterial infection, and then the lymphocytes, which are a different group of white blood cells that typically are elevated in viral infections in general. These are just broad general terms that can, in specific circumstances, things can be different all the time.
So what about the neutrophils and the lymphocytes in Corey's white blood cell count when he was at Jersey Shore less than 24 hours before he was pronounced?
They were completely normal, and the distribution was normal. There was nothing striking. It just looked like a normal child CBC, complete blood count.
And you mentioned that everything else in the blood work, as far as you're concerned, was normal and unconcerning.
Right.
Was there anything within those Jersey Shore records that was important to you in regard to formulating your opinion, or what did that mean to you, the Jersey Shore records?
Right. Well, and the concern is that typically children develop pneumonia following a respiratory viral infection. That the virus sets them up to get a bacteria into the lungs that can cause infection. And at this juncture, not only was he afebrile, looking completely well, he had no evidence of typical respiratory virus. Now, they didn't test for all of them that are possible, but the big four that we worry about were ruled out at this visit.
Now, taken together, what, if any, significance did you assign then to those 3 medical evaluations that Corey had, the 2 that occurred on April 1st, and the one that started in the late hours on April 2nd and ended in the early morning hours, in the late hours of April 1st and ended in the early morning hours of April 2nd?
So just, reviewing this history, this child was seen 3 separate occasions by 3 physicians, and nobody felt that he had any sign of infection and that there was anything wrong other than the bruising. And so at this point, when he leaves the Jersey Shore Medical Center at, I think it was 1 a.m. on the 2nd, he's a well-appearing child from an infectious disease point of view. He has no evidence of having an infection.
Now, in addition to the medical records, was the case history here important to you?
Yes. What the information that was reported was that Corey went home with his mom and went to sleep, and the next morning, according obviously to the mom and the grandma, the maternal grandmother, he looked well in the morning. And it was reported that he ate breakfast, bagel and yogurt, I believe. Children who are sick, and typically children who have fever or have a significant infection, have what we call anorexia. They don't want to eat. I mean, a lot of us don't want to eat when we feel really sick. So similarly, kids will not, wake up and eat their normal breakfast if they're ill or have a fever or are starting to get an important infection. It's just unusual.
Now, you had mentioned in the discovery that you reviewed that there was a video of particular importance to you. Could you tell us about that?
When I listened to the 33-second clip that was taken in the car, Corey spoke, not a lot, but he spoke to his mom, and he had no shortness of breath. So, sometimes when people will call us and say their child is having trouble breathing, and we'll say put the child on the phone and see if they can give a full sentence without having to take a breath. Or the other thing that was notable was that he never coughed, and you never heard any other sounds except for the mom and Corey speaking. There was no wheezing heard or anything like that. But just he clearly was speaking normally by report, and by the video he sounded like, a regular healthy kid.
So there's no moaning in that video that you heard?
No, none.
Now, if someone had actually been suffering from an infection, a real infection, what would you have expected to be different?
It would be unusual even for 33 seconds to go by for a child who had a significant pneumonia not to cough, or when they spoke to sound short of breath. To some extent, you can usually hear that in a child's voice.
So would you expect that a person that was sick with an infection would have trouble talking like you described, or walking, or climbing a set of stairs?
Yes, if somebody has a significant pneumonia, they get short of breath trying to do those things.
Now, what is your impression of Corey's condition later in the afternoon of April 2nd when he was brought to Southern Ocean Medical Center?
Well, at that time, he was obviously critically ill. He was described as ashen and very pale. He had what we call altered mental status, so he wasn't appropriately awake. He was described as somnolent, so that suggests maybe that something's going on in his head, or he's not perfusing well. He was disoriented. He was difficult to arouse. But despite those sort of severe symptoms that are extremely concerning, he had they described no abnormality on his listening to his chest. And they did say that he was breathing quickly, but there was no distress, respiratory distress, no retractions. That's when you pull so hard to bring air in that you can see, the ribs or the muscles. You can see the muscles of the neck working to help. And there was no wheezing, no crackles associated with pneumonia, no abnormality on the lung exam to suggest a pulmonary infection.
And those are all things that you would expect to see from someone that had a pulmonary infection.
Yeah, absolutely. And also somebody who comes in looking this ill, if this was due to a pulmonary infection, I would expect very significant changes in the ability to breathe and his pulmonary exam.
Now, are you familiar with the term agonal breathing?
Yes.
Could you tell the jury from your standpoint what that means generally?
Agonal breathing is the kind of breathing that you see when somebody's really sort of pre-morbid, really on their way out. And it's like a big short breath. They might gurgle, and it's a sort of a distinct kind of breathing that happens very close to death, and is usually patients are usually not there with it at the time that they have that kind of breathing.
And that's not like the wheezing or crackling or anything that you
No,
just described?
no.
Did you have the chance to review and compare the lab results that you talked about from Jersey Shore Medical Center late in the night on April 1st and the lab results obtained from Corey at Southern Ocean Medical Center on April 2nd?
Yes. And clearly the laboratory data was different. The white blood cell count was markedly elevated. And and there was a somewhat larger number of the neutrophil counts, those cells that I say often respond to a bacterial infection. And there were some premature forms, white cells that had come out of the bone marrow before they were completely mature. So that was different compared to the evening before when his white count was normal. In addition, his glucose was markedly elevated. The amount of base in his bloodstream was very low, so he was acidotic. His blood was, the pH of your blood is something that your body tries to maintain all the time around a normal value, like about 7. And his was low, and we know that because the amount of base there was very low, and the amount of lactic acid there was very high. So this occurs anytime, or can occur anytime you are critically ill. And the message to your brain when your blood is acid is breathe quickly. Try to get out the CO2 as much as possible so that we get back to a regular balance of the pH. So patients, we see this all the time in children with diabetic ketoacidosis, kids with diabetes who come in and they have too much acid, they're often breathing very quickly.
So when you talked about shortness of breath and tachypnea earlier, that has to do with Corey being acidotic.
I believe that was the explanation for his tachypnea in this situation.
All right. And you said that you compared the white blood cell count from Jersey Shore to the white blood cell count at Southern Ocean Medical Center. What was the difference?
The difference was that he had a much more elevated white blood cell count.
Do you recall what it was at Jersey Shore?
It was 7.5, and here it was 29.9. So
that's a large increase?
Yes, that's a very large increase.
And did the neutrophils and the lymphocytes that you defined earlier, did those shift?
They shifted, yes. He had more neutrophils and more of these immature cells in the bloodstream.
Is an immature cell a monocyte or a band?
A band.
A band. Okay. Now, what are the laboratory changes noted in Corey consistent with, in your opinion?
So, in my opinion, these labs in Corey, putting them all together, are a response to a giant surge of epinephrine. So that's a stress response. So if the body's put under a very stressful situation, this happens with, it certainly can happen with infection, but it can happen with any number of things, including blunt trauma is a well-described cause of, Cooper, we have a lot of trauma patients. We're really the trauma center for South Jersey. And patients that come in with trauma always have very elevated white count because anytime you surge your epinephrine, you release a lot of these cells into the bloodstream. The other things that really suggest that are the elevated glucose. So Corey's glucose was 400. That wasn't because he had diabetes. It was because he had this surge of epinephrine in response to whatever stressful event occurred, and that caused these changes in his blood counts.
Is elevation of a white blood cell count a specific or non-specific finding?
It's a non-specific finding. It can be a sign of infection, and we do look at it, but it's clearly not the only reason. Infection is not the only reason that a white blood cell count goes up.
What's like a specific finding versus like a non-specific finding, if you kind of explain what those two things are?
Well, a really specific finding would be finding bacteria in the bloodstream. That would be, proof that, or finding in bacteria in your urinary tract or in your spinal fluid. Those are really more definitive, evidence of infection. But it's all, you have to put the whole picture together.
And that's why you're referred to as a detective in your field.
There you go.
Objection.
Now,
Sustained.
did you review Dr. Ragasa's report?
I did.
And did you agree with his interpretations?
I did not agree with his interpretation of the finding of Staph aureus. I can't comment on his, autopsy because that's nothing I am an expert in.
Was there a post-mortem CT scan conducted?
There was, and again, from my understanding, post-mortem CT scans are not helpful and not actually used in the diagnosis of pneumonia. So when you die, your cells that keep everything where it belongs, keeps the blood on one side and the air on the other side, keeps water where it's supposed to be. When you die, all those cells start to die, and the mechanism where they transport things from one place to another disappear. So you're going to collapse your lungs. There's nothing to hold air in your lungs. And the literature suggests that post-mortem CT scans, the only way they're valuable is if you go to the trouble of actually inflating the lungs. So, you keep the patient or the body, I guess at this point, intubated, and you put positive pressure to get air back into the lungs, and you hold that.
Judge, I'm going to object. She just stated that she's not an expert in forensic pathology.
This isn't pathology. I'm really talking about the.
I'm talking to the judge.
I'm sorry.
You're decided. Ladies and gentlemen, thank you for your patience. I've overruled the objection, but I have asked Ms. Strong to ask a few more questions to develop that area of testimony if it's appropriate. Ms. Strong.
Dr. Feingold, given all of the training and experience and the patients that you've seen that you've described already, from an infectious disease standpoint, is it significant to you whether a lung that's imaged is dead or alive?
Yes.
And could looking at a living lung, an insufflated lung, be helpful to you in determining some type of infection, giving all of your training and all of your experience?
Looking at an insufflated lung on an X-ray or a CT scan?
Yes.
Yes.
Looking at a living lung and then looking at a dead lung that's insufflated.
Yes, that might be helpful, but I've never seen it done.
Okay. Now, when you say you've never seen it done, could you tell us what you mean by that?
I've never reviewed a post-mortem CT scan, and I have never, in my experience, heard of it being ordered.
And is that because you just haven't looked at them, or is that because it's something that's not really done in your experience?
In my experience, that's not something that's done
And you've reviewed CT scans as part of your job before, right?
all the time.
Now, what type of changes do the lungs go through, in your experience, from an infectious disease standpoint, after a person dies?
The lungs collapse and water leaks out of, and blood, because the cells that are supposed to keep things separate are no longer working. So what's described as sort of a wet lung. It just looks like it's filled with water because you can't tell, because there is no air to sort of see the difference between tissue and air, or what might, in a pneumonia, we often see significant abnormalities for significant pneumonias on a CAT scan in a living patient, because the rest of the lung looks like normal lung, and we contrast that with whatever findings are suggestive of pneumonia. But once the whole thing's collapsed, it just looks like kind of a big ball of water, sort of.
Do you recall about how long after Corey was pronounced that this imaging of the lungs was done?
I believe it was 3 hours.
So not immediately after it
Right.
was pronounced. From your perspective as a specialist in infectious disease, is there any value in a postmortem CT scan?
No. Can I just add that,
Objection.
to adding?
Doctor, why is there no value?
Staying because he answered the question, but Ms. Strong can ask other questions.
Thank you.
Sorry.
Why is there no value in that postmortem CT scan from your perspective?
Well, I'm just thinking that I want to make sure people understand that when patients die and we don't know why, we try very hard to figure that out using all the data we have available, and there's no evidence that CTing a lung after somebody's dead has been helpful in coming to a diagnosis.
So in your expert opinion, are the results of Corey's postmortem CT scan indicative of any type of pneumonia or infection?
They're uninterpretable.
Are you aware if there was a postmortem lung culture done?
There was.
Do you know what the result of that was?
Yes, that lung culture grew a bacteria called methicillin-sensitive Staph aureus in.
Now, what is that? Methicillin-sensitive Staph aureus.
Staph aureus is one of the most common bacteria around. It causes what we call suppurative infections characterized by pus. So boils and little abscesses, skin infections, but it can cause infections really anywhere. So it's a very common, but also bacteria that in fact lives on many people. In pediatric patients, you can swab kids' noses and find it about every 30 out of 100 kids will have Staph aureus just living on the front of their nose or the back of their throat without causing any problems. But it can, if it gets in the wrong place, it can make somebody very ill.
Now, could you tell the jurors if there's anything significant about the fact that this culture was done after Corey died as opposed to when he was living?
So the best way to explain this is just as I said that the CT scan doesn't help you post-mortem. A culture obtained after a patient's died doesn't help you in the course of and again, we try very hard to make a diagnosis in patients when certainly to figure out when they're alive how to treat them and to figure out when they're dead, you know, what the underlying cause was. And this has been studied, the value of post-mortem lung cultures, and they, because of the extremely high risk of contamination that occurs once you die and the breakdown of cells, that there's all the integrity of surfaces is lost and anything can sort of spread anywhere. In addition, when you intubate a patient because they're having an arrest, a cardiac arrest, and you then push air into their lungs, you can easily push whatever's in the back of their throat into their lung tissue as a, you know, because you're giving positive pressure, we call it. So that we don't know where that Staph aureus came from or what significance it has. And in the infectious disease world, there's no role for post-mortem cultures because of these issues, that they're so frequently contaminated and they haven't correlated with what has actually caused a patient's death or even an infectious death.
So is it fair to say that this post-mortem cultures or testing, it's not an accurate means of diagnosing pneumonia from your perspective?
Exactly. It is not.
Or other infection?
Because of the loss of integrity of all the cell surfaces and all the borders that make up our body between the bloodstream and the tissues or within tissues, that it starts occurring almost immediately after you die, in the infectious disease world, there's no value placed on post-mortem cultures.
Now, what would be the normal clinical course of a Staph aureus pneumonia, that type of bacteria causing pneumonia?
Right. So I've treated many children with Staph aureus pneumonia. As I mentioned, it frequently complicates respiratory illness, in particular influenza. But the typical clinical course is a child who's had some febrile illness, presumably some virus, and then has higher fever, develops more respiratory distress, trouble breathing, really over days becomes quite ill. And generally when we see kids with Staph aureus pneumonia, they have gross abnormalities on their chest x-ray, but they also have very abnormal exams when you listen to them. There's areas where you don't hear any breath sounds because the pneumonia has filled that space where you're listening with your stethoscope. The other thing that's very common with Staph aureus pneumonia is to have what's called an empyema, which is a collection of pus between the lung and the chest wall. So we often have to, stick a tube in there to drain all that pus so that the lung can expand. We often have to put chemicals in there that break up all the adhesions because, it's pus and it's very thick and hard to suck out. So this is usually a clinical disease that starts and then over days, and maybe even as much as a week, will get worse and worse until the child comes to medical attention. And when they show up, they have high fever, they have abnormal lung exams, they're having trouble breathing, they have stopped eating, they're quite ill, but it's and that's really what how we generally see this disease progress.
And Corey didn't have any of those things.
Had none of those things.
And you yourself have actually treated children that find themselves with Staph aureus pneumonia.
Absolutely.
Do you know if there was a blood culture done?
There was a blood culture done shortly after Corey presented to the emergency department at Southern Ocean Medical Center. In fact, that blood culture was obtained at 4:13, less than an hour prior to his death.
And you had said earlier that blood cultures are actually something that could lead to a specific finding instead of these other non-specific things that we've discussed, correct?
Yes.
Now, what exactly is a blood culture?
So what happens is that whoever obtains the blood culture cleans the skin very well with alcohol or iodine to remove whatever things are living on your skin. And then blood is drawn and it's put into tubes that have growth factors so that, if a bacteria is in the blood, normally your blood is sterile, but if there are bacteria in your blood, they have what they need to grow. And those cultures are then put into an incubator, and that blood culture is monitored for 5 days to see if any bacteria grow in that blood that's sent to the microbiology lab. And if something grows, they take that bottle, they do a gram stain, and then they do it all through technology. They have machines that will identify the organism that's causing the infection.
Did anything grow in Corey's blood?
His blood cultures were negative.
What does that mean to you?
To me, it rules out Staph aureus sepsis as a cause of death in this patient. Any one of us who is about to die from Staph aureus sepsis less than an hour before our death, if we'll have Staph aureus in our bloodstream. It means the system has been overwhelmed. So you can have Staph aureus pneumonia without having a positive blood culture. But if you say that patient then developed sepsis, so had the bloodstream contaminated with that bacteria, that's invariably going to be there as you approach sort of the end of your course. So to me, that's one of the most specific pieces of evidence that this was not an infectious death due to Staph aureus. Staph aureus is a bacteria that's very easy to grow. It's not one of these bugs that we sometimes have trouble growing or identifying. So that close to 45 or 50 minutes before Corey died, he had no bacteria in his bloodstream, which, if this was a Staph aureus sepsis death, should have been teeming with the bacteria. The fact that it wasn't there, to me, means that this was not the diagnosis.
So is like the bacteria in the blood, is that kind of like the missing link between the pneumonia and a sepsis?
Exactly. So sepsis occurs when bacteria get into the bloodstream, and then it sets off this cascade of an inflammation in the body. And that's what, it's actually our immune response that makes us so sick, not just the bacteria, but the bacteria cause all these toxins to be elaborated.
So is that what sepsis actually is, what you just described?
Exactly.
So this negative blood culture is then completely inconsistent with sepsis.
Exactly. With bacterial sepsis.
Now, why are all of the circumstances present in Corey's particular case not indicative of an infection like pneumonia?
Neither Dr. Ragazza nor Dr. Andrew found evidence of essentially infection in the lung, pus in the lung, tissue death, necrotic lung. There was some hemorrhage, but if you die from a Staph aureus pneumonia that then gets into your bloodstream to ultimately kill you, you would expect on autopsy to have lungs that have been, battered by Staph aureus, that have had pus fill the air spaces, have made abscesses in the lung. None of those findings were described in the pathologist's evaluation. And there was the clinical story, the course just doesn't make sense for infection. You get seen 3 times right up to the very end, and nobody thinks you're sick. And then you come in and you're premorbid. That's not how Staph aureus infection acts. That's not what, and I've been taking care of children for 40 years, and the last 30 as an infectious disease doctor. I see every case of Staph aureus pneumonia that we see in the pediatrics department, and nobody presents like this. Kids don't come in and die from Staph aureus sepsis without some prologue and some leading up to it, and being sick before they, become so ill that they need help to manage their sepsis. And the lungs show tissue destruction, necrotic lung, purulent collections.
So in sum, Dr. Feingold, what, if any, conclusions did you reach whether an infection caused or contributed to Corey's death?
My conclusion was that there was no evidence that Corey had an infectious disease at any point, and certainly that was not his cause of death.